My name is Anessa Mir, and I'll be presenting on the article titled Adverse Sedation Events in Pediatrics, a Critical Incident Analysis of Contributing Factors. I will be giving a little information about the article before going in depth about what the article is about and giving my own analysis of it. So, as I said before, the title of it is Adverse Sedation Events in Pediatrics, a Critical Incident Analysis of Contributing Factors. The authors are Charles Coate, Daniel Nottaman, Helen Carl, Joseph Weinberg, and Carolyn McCloskey. It was an article, a part of the Journal of the American Academy of Pediatrics, and it was published in April 2000. This article, it was a critical incident analysis, and this is where an analysis is done into an event that occurred to find out what were the causes leading up to the event to prevent it from occurring again in the future. The American Academy of Pediatrics and the American Academy of Pediatric Dentistry published the first guidelines for caring for children requiring sedation for procedures. Despite these guidelines, there still remains adverse outcomes, so this paper sought to find out what were the reasons for this. So the purpose of the article was to determine the factors which contribute to adverse sedation events in pediatric patients. There have been standard policies that have been developed regarding administering anesthesia to pediatric patients, so the authors of this study thought that it would be useful to find policies for sedation as well. So the study was done to see what new policies could be developed after finding out what were the reasons for the adverse outcomes. So next, I'll be talking about the methodology and the study population that was included in this study. The study population were patients under or equal to the age of 20 years. Reports were received from the Food and Drug Administration and the U.S. Pharmacopoeia, and these associations, they have a requirement to report any adverse drug reaction, so this is the way in which these reports were obtained. Reports were also obtained from pediatric anesthesiologists, pediatric intensivists, and pediatric emergency medicine specialists. And the way in which this was done was that a survey was mailed to each of them, which was then returned. At first, each report was analyzed independently to minimize bias that a collaborative discussion may cause. The responses were sent to a statistical analyst who assessed the level of agreement among the group. The group then had a discussion, and only when a consensus was arrived was the report included in the study. So initially, there were 118 reports, but after the collaborative discussion, 95 studies were selected. Outcome was divided into 4 categories: death, permanent neurologic injury, prolonged hospitalization without injury, and no harm. So as was said before, only 95 of the reports was a general consensus was able to be made. Of that 95, 51 resulted in death, 9 resulted in permanent neurologic injury, 21 in prolonged hospitalization, and 14 in no harm. The study also looked at a positive outcome versus a negative outcome based on the location of where the procedure took place. So a negative outcome would be death or neurologic injury. Positive outcome would be prolonged hospitalization or no harm. So for procedures that took place in the hospital setting, 37.2% resulted in a negative outcome and 62.8% resulted in a positive outcome. In the non-hospital setting, 92.8% had a negative outcome and 7.2% had a positive outcome. The study also looked at negative and positive outcome when monitoring and no monitoring was done. And the monitoring in this case was pulse oximetry utilization. So in the cases where pulse oximetry was monitored, 17 of them had a positive outcome, while only 4 had a negative outcome. When no monitoring was done at all, 14 had a negative outcome, while 4 had a positive outcome. This table, it just shows the category of causes that the specialists credited to what caused the adverse sedation events. And we can see that the most common causes are drug-to-drug interaction, drug overdose, inadequate monitoring, inadequate resuscitation, and inadequate medical evaluation. And this is the same regardless if it's a hospital-based or a non-hospital-based setting. Okay, so for my own assessment of the article, I think the use of a critical incident analysis was appropriate, as this is an effective tool in determining what went wrong in an adverse event and why it went wrong. I think the inclusion and exclusion criteria were very appropriate. They wanted patients 20 years and younger, and this kind of encompasses pediatric patients. The cases, they were evaluated by 4 different persons: 2 pediatric anesthesiologists, a specialist in pediatric critical care medicine, and a specialist in pediatric emergency medicine. And the cases, they were not selected unless all 4 of these persons agreed. This limited the chance of bias. In addition to this, even when they did their own individual analysis, when checking for the level of agreement, there was found to be a moderate level of agreement, and this proved that the agreement was not by chance alone. A limitation of this was that there was reporter bias. So there's a reluctance of practitioners to report adverse outcomes, as they don't want their name to be associated with this adverse outcome. In addition to this, practitioners, they tend not to report adverse outcome unless it's severe, such as death. So there isn't an accurate reports or information on the other outcomes. So these may limit the results of the study. So in conclusion, the most common reasons for adverse events, as proven by this study, are they were related to effects of drugs on respiration, inadequate resuscitation skills of the practitioners, inadequate monitoring, and inadequate pre-procedural evaluation. So as a result of this, practitioners should take more time to take a proper history and do an examination. They should ensure that patients have followed fasting protocols, as well as there should be enforcement of a minimum standard of training. Practitioners should be trained in airway management and resuscitation skills. There should be adequate equipment. There should be a standard discharge criteria, and there should be monitoring of patients with pulse oximetry. And with the enforcement of these policies, there should be a decrease in the amount of adverse sedation events in pediatric patients.
End.